Hello. I am Kristen Fucci. I am here to present therapist safety and how that presents predominantly for outpatient services, but obviously applicable things will be shared for any setting that you're in. Um, I am the clinical director at Resolve Counseling and Wellness and have been here for 6.5 years at this point in some role. I am clinically licensed in Kansas and Missouri and have worked in multiple settings along the way in my 15 plus years as a therapist. So I also want to definitely state that I am not an expert in therapist safety and have done as much research as possible to provide as much information for you to absorb and then to use and decide what's best for you and your practice, depending on how you practice. So as we move through this, you may have questions or you may think, I don't know if that's applicable to me in my setting. That's completely fine. But just want you to have as much information as you can to decide what's best for you. And let's go ahead and get started. Talk about the objectives for um, the rest of this training. So, what we want to do is we want to identify strategies to use for virtual and or in-person sessions for any clients who present as either intoxicated, under the influence, who also could possibly present with any aggressive behaviors, whether that be verbal, physical, and then any clients that may present with any sexually inappropriate behaviors. And those, as we'll talk about in a little bit, can go from very mild to even just an innuendo from a client to you as a therapist to um, sexual inappropriate physical behaviors during session to stalking behaviors, whatever it may be. So they can range in a variety of different ways. So obviously something to talk about is safety. So how do we even define it? Many times being a psychotherapist, we think about and discuss and have classes around client safety. How do we provide safety in form of psychological and emotional safety? How do we provide even physical safety in our office for the client? But unfortunately, many times what's not approached or discussed is safety for the therapist. So what does that mean? So one of the things to help start out is to just define what does safety even mean? So according to what I found in different places, it's freedom from the occurrence or risk of injury, danger, or loss. So in mental health, like I said, we often consider the physical and emotional safety of our clients, but very rarely are we having conversations about safety for us as a therapist unless something comes up. And so I'm hopeful that as we talk today and as I present today, that you start to think, oh, I could be more proactive in this and have a plan and have something designed to help me deal with if these things ever come up, because that's part of our safety is wanting to prevent the occurrence of something happening. Okay, so being proactive in that sense. So with the different things to keep in mind, um, you know, there are stereotypes of therapists, and the physical danger from patients is often kind of not necessarily blown out of proportions, but maybe out of proportion to what true statistics are. And we'll get into those statistics here in a minute. But there are certain risks, both physically and psychologically for therapists. We're dealing with many different things with patients and clients that may be unpredictable just in nature due to their own mental health diagnoses and inability to deal with things that are happening in their life. It might be that they might be aggressive. They may be, there could be a potential for physical violence and or sexual violence. And so depending on the populations that you see. But beyond like physical safety, we also need to think about our own emotional and psychological risks. Burnout is definitely one of them, compassion fatigue, and then vicarious trauma. So those are all part of our safety and our longevity as a therapist. So when we talk about physical safety, what we talk about is that unpredictable patient behavior sometimes. So excuse me. Therapists may encounter patients who are agitated, are physically aggressive, possibly even during a session, especially when discussing sensitive or what we call triggering topics. Um, we also are possibly having discussions about significant loss and grief and feelings of things not being fair. And those are many times triggers for people to escalate their behavior. And so being mindful of that, and having that in the back of our brain as we're working with clients. The next thing to think about, especially in healthcare professions, is workplace violence. We have people under a lot of stress, and our clients are part of that. And so it's just being aware of what could happen to help protect ourselves in the long run. Um, One of the things that helps protect some level of safety is making sure that we're really good at assessing, and using evidence-based tools to help us assess. And we'll go over some of those in the future slides. But there are still, situations are going to arise that are not going to be able to be predicted and can happen unexpectedly and escalate very quickly. So when we think about the emotional and psychological impacts of the work that we do as us as a therapist, one of those big things is compassion fatigue. So we might develop that over time, when we're really sitting with client after client or patient after patient and just hearing the difficulties in their life, and the struggles that they're going through. And sometimes that's really hard to then be present for ourselves and for others in our life. And so it leads to emotional exhaustion. So we need to be proactive in that sense too. Vicarious trauma is another thing that we deal with on a regular basis, being psychotherapists. Hearing about traumatic experiences over and over and over again impacts our own worldview, our own sense of belief. And so we have to be aware of that and work on that, for compassion fatigue and vicarious trauma on a regular basis, in order to, like I said, have a long, fulfilling career and be mindful of that. So obviously, one of the things to be thinking about, for our psychological and emotional safety is making sure we are taking care of ourselves. So self-care, self-care, self-care. We hear those words all the time, but really making sure that we're to have good self-care practices in place. We're seeking supervision and consultation on a regular basis. We're setting healthy boundaries. And if you struggle with that, please get help from others around you to set amazing boundaries to protect yourself. And also it helps protect our clients to help mitigate all of those emotional and psychological risks, from really making an impact on yourself. Okay. One of the most important things to even think about is to be aware and then also be prepared. So those two things alone will help you remember that you are an active participant in your own safety and the safety of our clients. So so there are some indicators of increased risk, of possibly being someone that is subjected to either, an aggressive client, sexually inappropriate client, and not being able to be prepared to deal with possibly an intoxicated client or someone that presents as under the influence. So one of the biggest risks, there's four here, is being a newer therapist. Okay. So you don't have the experience, you don't have the additional training, you might not have, um, might be a little naive to what could happen. And so you're not prepared for it as much. So one of the things that really leads to that is the lack of training in either your master's program, doctoral program, whatever program you're in, like I mentioned before, there's not a lot of training about how to keep yourself safe. We're really focused about how to keep the client safe or the patient safe, which obviously is a big part of what we do. At the same time, we really need to figure out how to keep ourselves physically and psychologically and emotionally safe. So, being a newer therapist, sometimes there's some studies out there that say newer therapists may just be less alert to cues of violence. You don't have the experience, so you're not looking for certain things as much. They might actually set, as a newer therapist, you might set fewer limits or allow maybe aggressive behaviors to escalate, or for someone intoxicated to repeat it, or you're less likely to set very firm boundaries with clients. So it really impacts those newer therapists that are in inpatient care. They're more likely to be around patients that are going to be more erratic and have more severely impaired mental health. So those newer therapists in inpatient care need a lot of support, a lot of training. So as I mentioned, one of the increased risk factors too is whether do you work in inpatient or do you work in outpatient care? Inpatient care, you are more likely to have a situation where a client is violent and or threatening in some way, just due to the acuity, the severity of some mental health diagnoses, the chronicality, the substance use impact on it, change in medications that are happening, the fact that they are unfortunately and fortunately, they're like trapped in inpatient care. They're not able to leave. They're not able to just walk out the door. Many times that's triggering for some patients. So it's that extra awareness that if you work in inpatient that you need to have and you need to plan for in some capacity, not just for the hospital or the unit, but literally for yourself. Versus outpatient care, um, more likely to have patients or clients that are less acute. Um, if depending on your specialty, depending on who you work with, you're typically less likely to have the patients and the clients that are dealing with psychosis, um, lack of touch with reality, and having more outbursts are more likely to happen to inpatient. So just depending on the setting that you work in, that increases your risk as well. The next thing that tends to increase risk is whether if you're working in outpatient care, do you have your own individual practice or work individually in some capacity, or do you work in a group practice? Those that work in individual practice need to have additional plans and additional safety things put into place versus group practice, because group practice, you're typically around other people. There's typically ways to reach out literally to the next office or even in the hallway. You're using the same exits and entrances. You are able to look out, support each other, say, hey, I have this client coming in. Last time they got a little agitated. So either, I'm gonna leave my door open, or hey, if you hear voices, would you please knock on my door? So having that support right there when you work in a group practice versus individual practice, you are kind of on your own. You're gonna have to figure out what that looks like. Who are your emergency phone call people that you can have your phone right next to you? And we'll talk more strategies here in a little bit, but you're more likely to be a victim, basically, of either aggression, sexual inappropriate client, when you work in individual practice. So it's just something to know that that increases your risk as well. That next thing that increases your risk is whether you're a male therapist or a female therapist. And I hate to get genderized here, but this is how the research is set up. Male therapists are more likely to be physically assaulted than female therapists. There are many reasons behind this, according to the research. One of them is male therapists typically get assigned aggressive, more likely to get physical patients than female therapists do. There is that bias and genderized assignment of clients that is happening. Less there are less female therapists that feel comfortable dealing with physical or threatening or escalating clients, and so they get more likely sent to a male therapist. There are also typically, according to research, more male therapists in inpatient care versus outpatient care. Don't know why, don't know how, but that is also why it's almost like a double up. You work in inpatient care and you're a male therapist, you're more likely to be physically assaulted, threatened, and so things to be thinking of, depending on what group you fall into. All right, so let's talk about some statistics. I just put a couple different ones up there, but I'm going to give you a lot more information. So depending on what you are thinking about, you're going to hear even more statistics. So just in general, 60%, according to this study from 2019, 60% of mental health professionals experience patient violence or threats in some capacity in their career. Okay. Approximately 20% of mental health professionals have felt physically intimidated by a patient. So depending on how they stand, how they present, where they sit, those types of things. And then to go into sexual inappropriate clients, over 50% of female therapists experience sexually inappropriate behaviors by a client. There is a huge spectrum of what that looks like. And I mentioned that a little bit earlier, that sexually inappropriate is defined. It's actually not really clearly defined, but it can range all the way from an innuendo. It can be something like, oh, I find you attractive, or you look really pretty today, all the way to being sexually inappropriate behavior. So masturbating in front of you, showing body parts to you, with no consent, with consent, whatever it may be, asking a person out on a date. It can go from one end to the next. The hard part about this, and we'll talk about a little bit, is the limitations of where these statistics come from. We'll talk about that here in a little bit. So when we talk about violent behaviors, okay, I'm going to actually read a couple different things to you. So one of the things to think about is aggression rates, specifically in outpatient therapy, is what I wanted to talk about today. And so here's some other statistics for that. So verbal aggression, the most frequent form of aggression reported by therapists, and it's from a 2023 study of counselors in the United States. 51% had personally experienced verbal assault. So a client is unleashing their verbal wrath upon you from a client. And 75% of a somewhat different sample of counselors reported experiencing client-initiated verbal workplace violence. So coming to your workplace to threaten you, to, I don't know, like slamming doors, even all the way to putting their hands on people. So 75% of people have experienced that in their workplace with clients initiating that. So there's also physical threats. About 1/5 of counselors in one study had experienced physical threats from a client, while another national survey, nearly half of psychologists specifically had been verbally threatened. There's also, one of the things I didn't mention earlier was that psychologists and psychiatrists are more likely to increase, their risk is increased because they're typically seeing clients that are either being assessed for either higher levels of care, for medication changes, for addiction issues, for psychosis. And so the clients that they typically see are already at a more higher risk. Okay. So one of the things to the last thing to think about as far as according to, aggression and intimidation by a client is actual verbal aggression, of course, is still a risk. Well, one of the things to think about is physical violence. Like, how often does that really happen? According to one study, approximately 3% of counselors will experience physical assault by a client at some point in their career. Okay. Doesn't sound like a lot, but it's enough. It's more than needs to be. And so we never know when we're going to be part of that possible 3%. Okay. So those are the things that I just kind of wanted to mention. This is an occupational hazard and it's something to consider and something that we need to plan for in some capacity. Okay. So the next group of things to think about is, what do we consider aggressive behaviors? That can be all the way from verbal aggression to physical aggression, of course. There's threats. If you do this, then I will do that, type of things. There's passive aggressive behavior, can also be a big part of it. So whether it's sarcastic remarks, giving a silent treatment, purposely not responding in situations, especially if you're trying to assess for safety and those types of things, that is considered a form of aggressive behavior. And then, of course, threatening body language. So if you see the jaw tense up, you see, that somebody stands up in the middle of session and starts pacing around, clenching their fists, or, and then any hostile facial expressions, all of those are considered part of aggressive behaviors. Okay. So when does the risk for aggression increase? Mental health conditions. So those with a higher risk of aggression are diagnoses of schizophrenia, bipolar disorder, personality disorders, and those experiencing dementia. Okay. Substance use. So any co-occurring substance use disorders will significantly increase the risk for increased aggression as well. So something to consider if you are an addictions counselor or work with those with addiction, something to be mindful of that increase your risks. Any prior history of violence, so past aggression or violent behavior is one of the strongest predictors for future or current violence. And then some demographics. So there are some demographics out there that indicate that younger male clients are more likely to exhibit aggression versus other populations. So just things to be aware of and to think about. So the next section to talk about is sexually inappropriate clients and some statistics around that. Okay. So what do I mean? And we talked a little bit about, like, what does sexually inappropriate behaviors look like? It can go from all the way to an innuendo of your looks or them being attracted to you, to actually coming and doing some behaviors, whether it's in person or on a virtual session, of, like I mentioned before, masturbation, showing body parts, and going all the way in that direction. So here are some additional statistics. So as I mentioned before, over 50% of female therapists experience some kind of sexually inappropriate behaviors by a client. Okay. Most are considered mild, but even mild, if it feels inappropriate, makes you feel uncomfortable, that will lead to burnout. That's going to lead you to not wanting to do the work that you want to do. And so be mindful of that. So one of the things I mentioned before, if there's a psychiatrist in this group that's listening at this point, there's one study that showed 827 psychiatric trainees from many different countries. So it wasn't just a USA study. And approximately 84% had experienced some form of aggression, which could have included sexual aggression as well. 84%. So that is a very high number to think about when we're talking about inappropriate behaviors by a client. Okay, so specifically sexual behavior. What's the prevalence really of inappropriate sexual behavior by clients? So there was a study in let's see, make sure I say this correctly, in 2024 regarding therapists that said approximately 69% of female therapists and approximately 42% of male therapists had experienced some form of inappropriate sexual behavior by a client. Okay, so being a female, in that sense, actually your rate would be higher and you could be more susceptible to it. So here are some risk factors of what they found that may increase your risk of a client displaying some inappropriate sexual behaviors. Male clients are more likely to do that. They're more likely to perpetrate sexual harassment than female clients. Severe mental disorders, the same ones I mentioned earlier, bipolar, addiction, schizophrenia, just that borderline clients as well, or personality disorders. The next thing to consider is cognitive impairment. So those that are cognitively impaired are more likely to not realize in some way that they've crossed a boundary or where the boundary even is. And so they're more likely to perpetrate. So they are more likely to demonstrate inappropriate sexual behaviors. So therapist characteristics we talked about earlier, that if you're a younger, less experienced female therapist, you're more likely to be at risk to be perpetrated, especially in sexual inappropriate way. And because you have lack of training. So getting training, seeking out specific training is going to help. So here are some consequences, and we'll talk about those a little bit more. So common responses for when either physical aggression or sexual inappropriate behavior happens, you're going to have decreased job dissatisfaction. Like I mentioned before, you're not going to want to do your job. So this puts you at risk. Loss of confidence in your skills and who you are, and as of being a therapist overall, and then just other stress related issues. So that's where the vicarious trauma, the compassion fatigue, and the burnout really take effect. Okay. So limitations, we're going to talk a little bit about statistics overall, and limitations is underreporting. These numbers may be skewed significantly due to not every therapist is reporting when these behaviors are happening. Some might not be as themselves triggered or tuned into it and might dismiss some simple things along the way. It depends on where a therapist's ethical boundary is. They might actually tune into it and give some feedback, especially in sexually inappropriate behaviors. There are clinicians, and we know that's one of the most common ethical complaints to boards is inappropriate behaviors with a client. So some might actually engage in it. So being aware of that. And then we're going to talk a little bit more here, a little bit about how do I address this issue and what are some strategies for me to do. Okay. All right. So next slide is just a simple quote that I wanted to just go over. Safety has to be everyone's responsibility. So whether you're in inpatient, outpatient, independent practice, group practice, you have to have a team around you or people around you. So everybody's on the same page in some capacity. So everyone needs to know that they are empowered to speak up when there's an issue, right? So if we don't speak up as therapists and say this is a problem, we're less likely to get supports with those problems. So whether it's with our liability, malpractice insurance, and if we're not saying like, hey, I have this client doing these things, they're less likely to understand or know what support we need. We have those around us that we consult with. If we're not speaking due to our own lack of confidence or our own inability to verbalize what's happening, we're less likely to get that support. So one of the things that I like to say as clinical director is like, if I don't know, I can't help. Or if we don't know, we can't help in some way to either, whether it's help you plan, change a policy, correct a client for you, whatever it may be. So just continue to advocate for yourself and empower yourself to speak up. All right, so let's talk about virtual session safety. So if you have a client that presents is sexually inappropriate, intoxicated, under the influence, and or physically aggressive on a virtual session, let's talk about that. Okay, so strategies for in the moment. So you are on a session and a client is presenting in one of those three ways. What do? The first thing is to know your assessments, your risk assessments, to assess what the current behavior that you're seeing is happening. Okay. And there are a lot out there, and it is on us to have those assessments, to know how to use them, to have them accessible, to be ready in a moment's notice, let's put it that way, to be able to use those to say like, oh, we're at this level. I need to do this then next, which goes into safety planning. So knowing your risk assessments. Many people know risk assessments for SI. Okay. We use the Columbia, we use PHQ-9, whatever it may be that you choose to use. You practice it. You might even do a CEU on it. Okay. But how many people know of how do I assess in the moment, either intoxication and or under the influence? Okay. How do I assess whether this is sexually inappropriate behavior is something I'm comfortable working with or not, or do they need a high level of care, whatever it may be, and or aggression, okay? So for sexually inappropriate behaviors, there are two that I'm going to mention today of assessments to possibly take a look at and get to know to determine if you want to use those in your practice. So you have an evidence-based assessment for those specific behaviors. One of them is the PSE, which is the psychosexual evaluation. Okay. The next one I'm going to mention is the SBRA, which is a sexual behavioral risk assessment. Both of those tools can be used. They are actually, I believe both of them are therapist filled out, not client, versus some of the aggression ones that I'm going to mention are client reported. So then that way you wouldn't be asking the questions. They would just be, they could just fill those out online even before the session starts. You have your answers. If depending on how you do intakes, we'll talk about that here in a little bit too. You could send those out prior to get some feedback on them. So aggression risk assessments, I have three. One of them is the HCR 20V3, which means it's the 20 questions, but it's version 3. It's called the Historical Clinical Risk Management tool. And so using that, it takes a whole history of prior aggressive and or violent behaviors, which, as I mentioned before, is a big indicator for current or future behaviors. And so it kind of gives you an overall viewpoint of the likelihood that this may happen. And so that really helps with safety planning for yourself and for the client. The next thing is the BPAQ, which is the Buss-Perry Aggression Questionnaire. Very simple, easy to use. The next one is MOAS, which is a Modified Overt Aggression Scale. So those are specific things that you're going to see. And that's going to be a client or a counselor or therapist filled out one versus the first two are actually filled out by the client. So then that way it's their own version of themselves. And we have to always take that with a little grain of salt and say like how honest and how in touch with their behaviors are they. And so depending on what assessment you choose to use, be mindful of that. Okay. So with that, The next step would be safety planning for you and the client. Okay. So safety planning for a client, we're very familiar with that when it's regarding SI or HI. What we have to be mindful of is if a client is also at risk for sexually inappropriate behaviors, if you're working with addictions and it's likely that they could possibly be intoxicated and or show up under the influence, and then of course with aggression. So how do we safety plan for those? Very similar. What are the triggers? What are the indicators that my behavior is here? And then what do I do next? How do I stay safe? How do I keep people around me safe? And so it's going through those safety plannings with clients. As a therapist, what do we plan for? I think we're all surprised when something happens that we didn't plan for. So I think it's looking at that on a regular basis and being like, am I prepared? And what do I do if da da da? So looking at like what do I do and how do I keep myself safe for this when it happens online versus in person. So one of those things to notice is obviously when you're doing virtual sessions, that might be suggested for clients that are more likely to be physically aggressive in the beginning of a therapy due to them not possibly having the skills yet to manage their upset. So that might actually be a tool to use to help that in some capacity. Um, but a lot of times what we're going to do is we're going to try to de-escalate the situation. Okay. So depending on how comfortable you are with those different techniques, things to think about. Of course, there's three different things: active listening and emotional validation, nonverbal communication, and then setting limits and offering choices. So within active listening and emotional validation, the different things that we do is paraphrasing. It sounds like you're feeling isolated and unsupported right now. Yeah, yeah, I am. Those are not the moments to challenge or reframe those types of things. We want to go with exactly what they're saying and let that be the truth in the room in that moment, to try to de-escalate where the escalation is possibly going to happen. The next step would be summarizing, which is very similar to paraphrasing, but looking for those big themes or those main things behind what they're saying. So you feel like things are out of control, you're not sure where to turn for help, and it's like, exactly. And so they're more likely to de-escalate in that moment to try to join with you in some capacity, even if they're trying to get you to join with them in their anger or in their addiction or whatever it may be. Reflection is I can see the situation's causing you a lot of frustration. So these are many times skills that we're actually even teaching our clients on how to use, but we are using them along with them at times. So try to remember that. So the next one's nonverbal communication. So what's your body language? What are you giving off? Are you demonstrating scared or are you meeting their escalation? Are you like, you have to be mindful of your own body language. Sometimes it's actually more difficult in person versus a virtual and vice versa. I've heard it both ways. That sometimes virtual it's more difficult because you're only seeing this portion of them. So it's like you have to be very in tune with what's happening in nonverbal communication. So whether you're watching them, they're also watching you. So we have to be very mindful of how we present. Okay. So are we presenting empathetic and understanding? Or are we looking dismissive? Are we shutting down? Are we getting scared? And then they're going to pick up on that as lack of engagement, and that might actually escalate them. So being mindful of that. So some of the things to be really mindful of in nonverbals is open posture. So keeping our shoulders back, keeping ourselves sitting up to make sure that we look open. We're not shutting down, we're involved, we're engaging with them in full capacity. Also managing eye contact. If someone is escalated, direct, consistent, persistent eye contact might actually escalate them more. Okay. So there's a balance there of, hey, I see you, but I'm also not gonna be boring into your body with my eye contact to try to escalate things even more. So we have to find a balance, and every person is a little different. So that's one of those clinical skills and or judgments that you get to use. The next one is calm movements, which virtually I would try to keep your hands down, not up here and talking. You might see that in a client. You might see a client get up and start walking around the room as they're trying to talk to you. You're going to be managing your tone, the rate of the words that you say, how you say them. Hopefully, you're going to have somewhat of a relationship with them. You're going to be mindful of their triggers and knowing how, what different things kind of set them off. This will look a little different, and we'll talk about that here in a little bit with in-person sessions. Okay. So the next thing is setting limits and offering choices. Okay. So in that time, trying to have some kind of, hey, I really want to hear what you have to say. Like, I would like a turn two. Is it a good turn right now? Or do you want to go, do you have something you want to finish? Like being able to make sure that it feels like a collaborative conversation and you're using clear and calm language. Like, hey, let us both speak at a time. And then that way I can understand what you're saying and you can hear me. And that way we can communicate, you know. Um, if you escalate your tone and your volume just like they are, it's only going to escalate the situation. So we have to be very mindful of that. Also, framing boundaries. You have to set boundaries. Just by saying something simple like, I need you, or I need us to keep this conversation calm so we could figure out a solution. Okay. So like, can you come and sit back down? Would it be helpful just to do a deep breathing real quick? Like, hopefully you've worked on some coping skills in some capacity. Okay. Um, like the things that I have written down are, would you like to sit here? Or do you need to move to a different space within your house to talk? Like, um, we can pause if you need to. We can go, once you go get a drink of water and come back, and I'll be here waiting for you. Those types of things to kind of get the brain shifting to a different spot. Okay. So always know that if things escalate so much, whether it be, sexually inappropriate or verbal or physical in some capacity on a virtual session, you can always end a session. It is not required that you sit there and take that verbal abuse and or that you bear witness to inappropriate sexual behaviors. You would want to have some protocol in place. Okay. So what we talk about here, especially in virtual sessions, for emergency-based things, and hopefully you already do this, but especially for SI and HI, every single virtual session, you should be confirming where they are, excuse me, their specific location, address, um, and or are they alone? Is there someone else in the house? I mean, especially because you should be assessing for confidentiality every virtual session and documenting that as well. Okay. So if they're like, yeah, I'm at home, do you have their most recent address? Are you able to get to that quickly? So that way, if something would escalate, you're able to call 911 and get somebody there really fast. Okay. So that's first part of your emergency protocol for virtual sessions. The next part is, how do I deal with this in some capacity when it's a virtual session and I need to end session immediately because due to this and this and this and this. So what's your follow-up? Do you call within 24 hours? Do you immediately send an email? Um, do you have other supports in place? And so maybe you don't have to be the one to reach out, but maybe you have some assistance from another therapist or administrative staff or whatever it may be to help you in those, specifically in those moments. Do you have the 911 and or non-emergency number for wherever this person is? Are you able to give that information to a first responder? Okay, so those are in the moment strategies during the session. So what do you do after session, right? You get through that session and you think, oh my goodness, that felt not so great. What am I going to do with that? This is the different things that you can then do possibly after ending the session. A is professional consultation. So as I mentioned several times, as this is hopefully ingrained in your head at some point, if not already, that have those around you that are clinically sound, that possibly see either different and or same population that you see, that have the ability to help you walk through situations, conceptualize, and come up with a response and or plan according to your ethical background in whatever profession you're in. So if you're a social worker, if you're MFT, if you're a therapist, I mean, counselor, have those that have the same ethical background that you come from. So that you're more likely to see the situation similarly and or um if you're wondering like, oh, I'm wondering if I'm too pigeonholed into things, I need to actually reach out outside of my licensure and talk to somebody that is different than me. And so having a variety of different professional folks that you can reach out to. The second thing is documentation. So your documentation needs to include very specific things that are said or done by the client in that session, and then your response to it, and then what your follow-up is. And so being able to see and be able to document that very clearly, that's something else that other professional contacts can help you with. Obviously, you're not going to share the name of the client, all those different things, but it's like, how would I say this or how do I document this, and getting feedback from other people too. Making sure that documentation is done ASAP, like literally within right after the session and or definitely same day. You wouldn't want to wait a day or two. You're going to make sure that you're doing that documentation as soon as possible. Okay. Third thing to consider is personal processing. So who do I talk to about this? Sometimes it might not be a good idea to actually talk to the person in the next office as you. They're walking into their next session or they're dealing with what they're dealing with. So be mindful of that. Like, what is this impact? How is this going to impact my peers if I bring this to them? And at the same time, who do I offload this to? So having those professional consultees around you is obviously very helpful. If you have a mentor, a clinical supervisor, a clinical director, anybody in leadership or other roles within where you work, to just be able to offset that, debrief, be like, man, I just went through something that I never thought I would have to go through before, and I just did it, and it's really weighing on me. Obviously, having your own personal therapist is always a great idea, as the job that we do is demanding. And we talked about that vicarious trauma and that compassion fatigue, so being mindful of that during these processes as well. Something else to consider after the session is whether I'm going to transfer this client and or possibly terminate services with this client. Um, and being able to consider that as an option. Um, so what do I need to do ethically in order to make that happen, and being able to walk through that as well and consider that. Then, depending on the event, am I reaching out to 911 or first responder to file a report or to pursue criminal options against this client, depending on what happens, on what you feel most comfortable with. And so talking about that too, I'm obviously contacting your liability insurance and saying, hey, this just happened. I need to report this. So all those different things of strategies that you could possibly do after you end the session. Okay. So what about in-person session safety? Let's go there. So practical strategies. So let's talk about even just the initial visit. Do you have and use standardized risk assessments? I mentioned several of those earlier. Do I know how to use them? Do I know where they're at? Are they on my computer? Do I have it printed out forms? Are they easily accessible? So it's not in the moment and then I think, oh my gosh, now what do I do? Some people choose in practice to have phone consultations with new clients, especially if they indicate something on their intake paperwork ahead of time to say, kind of like walk through and say, and maybe that's when I'm going to use the standard risk assessment versus waiting for the first session or whatever it may be. So that's something to kind of consider, like, do I want to do phone consultation prior to that initial visit? And is that something that I want to utilize? The second thing to always think about is how clients enter your space. Okay. So use of cameras is recommended, whether it be in a hallway, it be in a lobby, it must be in a public space. I would strongly suggest if you choose to put cameras in your lock space to discuss that with your liability insurance. Um, and then of course, always having a locked door entry into your therapy space. So clients can't just come in. They have to be let into your space. So things to think about there. Your actual therapy office. How do you set up furniture in your placement into your office? Typically, always recommended that your seat should be the closest to the door. So if something does happen, you can stand up and you can get out as quick as possible. That is pretty standard practice in psychotherapy in making sure that you have that. Also, your accessibility to your cell phone during session. Do you have it sit right there? Do you automatically have it so you can hit 911 really quick, or do you use it to reach out, or you can also use it as a distraction, as being like, oh, I'm, having a family emergency, excuse me, and you can just use your phone, you can step out real quick. And thinking about your therapy office space too, of being strategic when you schedule those higher risk clients. Don't schedule the higher risk client if you're there alone at night by yourself. um, Schedule them during the day. If they can't come during the day, then do a virtual session, or that might be a time to refer out or whatever it may be like, no. But being mindful of when do you schedule your higher risk clients? Are you doing that when others are in the building at least and or around, or how are you going into practice with that? And then of course, peer support, immediate contact plan. Who, with my cell phone really close, who can I pick up and immediately get or send a text to, or get response from? At Resolve, we use the GroupMe app for each location. And so as soon if you need something, you're gonna pop on there and be like, help needed, room, whatever. And people are responding. So then that way you have help or assistance to hopefully de-escalate and keep things safe. The next thing to think about practical strategies for in-person is self-defense skills. I know that's required, I believe, for social workers, the first 2 years that you do your licensure, that you have to do a safety course of some kind. Um, Individual skill two is making excuse. Oh my gosh, my stomach is so upset. I gotta go to the bathroom. It gets you out of that space, it gets you away. So if you have to say a little fib or to get out away from somebody that's escalating, go. That gives you an opportunity to get assistance, call for 911, whatever you need to do. Okay. And then the other individual skill would be that de-escalation communication, which we've already talked about. Okay. So strategies for in the moment, very similar to what we just talked about. Um, the risk assessment, using those, knowing those, having them available, safety planning for yourself, having a plan, a place to go. Do I have a a safe room? Do I go to the business next door? What do I do if I'm feeling unsafe from client behaviors? What's my exit strategy? What's my escape? How do I do that? The other one is the de-escalation techniques, which we've already talked about. And then I mentioned making an excuse. So how do I get out of this space to reassert my safety in the moment? So then I feel safer, I'm able to do better problem solving, and I can go. And then, of course, that extra support. Who can I literally reach out to in that moment? And I mentioned those things before. Like, is it group me? Is it a group text? Is it my office mate that's right next to me? Do I have admin support? Whatever it may be. Do I just have 911? Boom, I hit the button, they're coming. Some people have looked up, and especially inpatient care, there's panic buttons sometimes in rooms, and so some people have looked into that. So it kind of just depends on what you feel most comfortable with. Okay. So things to do, things not to do. Okay, so adopt that passive, non-threatening body language. So how are you sitting in your seat? So if this person stands up and they start pacing around, how are you presenting? Are you standing up too, or are you not? Are your hands by your side? Do you have your palms up? Are your fists closed? Are you sitting on your hands? Like, what are you doing in those moments? And practicing those non-threatening um, body uh, postures on a regular basis. So it's not just in the moment where you're more likely to just go into um, your own survival mode. Okay. So always approach a client from the front. Don't approach them from the back. They're more likely to have a bigger reaction. Try to move a client to a no audience place. So maybe let's go walk in the hallway. Um, that way other people are still around, but you're not in a therapeutic space. Trying to keep others out of harm's way. And hopefully maybe it's a little bit quieter. Maybe it's not, kind of depending on what they need. Let the client vent a little bit, acknowledge their feelings, go into that de-escalation technique of paraphrasing and summarizing, and being like, and joining with them and be like, yeah, you're right. That doesn't sound fair. I think it's great that you're here to talk about it. Being able to show that it's okay to stay with that, and then maybe throw in but we do need to keep our voices down a little bit because we're going to impact people around us. And then sometimes that's the awareness for them to be like, oh yeah, to get them to de-escalate. Being flexible. Like I mentioned, hey, it seems like you're wanting to pace. Do you want to go outside and walk around? Do you want to go in the hallway? I can go get you a drink of water? Like, do you want to walk with me? Those types of things. Always, always, always position yourself near an exit. And that's what I mentioned before, just about furniture placement, making sure that your chair is the closest to the door if we're going to work with high-risk clients and or clients that could escalate at any moment. Here's the things don't do. Challenge or threaten the client through your tone of voice, your body posture, your eyes. Be like giving them, like I said, threats like if you don't calm down, I'm calling the police or something along those lines. Do not raise your voice at them, just like they're raising it at you. If you go to meet that, it only escalates things even more. There's nothing to argue about in those moments, to remember that. There's no right versus wrong. It's just de-escalating and getting to a calm place again. Don't turn your back on a client or rush up to the client really fast. Make sure you're calm and methodical in your movements. So the next thing to think about is don't ignore verbal threats or warnings of violence, and don't tolerate violence either. So that's reestablishing that boundary, and saying, if this is crossed, then this is what's going to happen. And that's not a threat. That's just saying, like, if you step up to this boundary and you cross it, I may need to refer you on, or I will need to terminate our relationship in a therapeutic sense, da 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 da. And being very clear with them. And of course, don't ever try to disarm a person. So if they present with a weapon, if you go to try to disarm them, your likelihood of being hurt and having the situation escalate is profound. I'll put it that. Okay. So the strategies after sessions are not too different. they're pretty much the same, depending on whether it's virtual or in person. Being mindful of that, that all these different things that you can do after session, to de-escalate yourself at that moment, to plan whatever you need to do. So therapist safety. So safety training is one of the best things that you can do. Literally actively seek out any kind of safety training. So how to look at your environment, how to set up your space, look to your liability insurance for risk assessments, reach out to local first responders, especially your police department. Many times they'll have people that can come out and look at your space and be like, hey, I'd think about this, or maybe look at that. Have other therapists come in your space and say, oh, I would probably, I don't know, move my chair there and move that lamp over there, or whatever it may be. Getting feedback from lots of people can typically help you. We only can see this much many times because we only know what we know. And so we're around other people. That usually helps. Obviously, a regular assessment of your client practice. I'm looking at the whole client experience. So as they walk into the lobby, how they get in my space, how do they get out of my space? How am I assessing for safety? How am I looking at this? And I would suggest, if not twice a year, maybe even quarterly, being like, okay, are we looking at these certain things? Staying updated with evidence-based risk assessments. And so that's for a multitude of different things. I mean, you could spend a lot of CE hours just doing evidence-based risk assessment research. Maybe that's what you choose to do with some of your CEU time. The next thing for therapist safety that is so important is consistent boundaries. Being very clear what boundaries are in session with you and or your practice and what that looks like if boundaries are crossed. Not just I'll share what the boundaries are and then leave it open, but it's like, if those are crossed, then this will happen. And making sure you're very clear with that in your policies and your procedures. Okay. So with that, I want to, of course, share all the resources that I have for you if you choose to do some independent practice and look at some of these articles and different things, to find out more information, or if you want even more statistics, there's plenty out there. I hope that you found this helpful. If you have any questions, getting together with other therapists, you're more than welcome to reach out to Resolve or myself if you would like to have any additional conversations. And I hope you have a wonderful day. Thank you so much for your time, and I wish you well.